welcome to the deep dive. Today we're tackling something pretty much every family experiences: fever in children.
Right. But we're going deeper than just general advice.
Yeah, we're diving into a really specific, well-respected source,
Yeah.
the latest Dutch primary care guidelines on kids with fever.
It's the NHG standard Kinderen met Koorts, M29 version 4.1 from May 2020. This is what GPs in the Netherlands use.
So our mission today is to pull out the absolute key insights from this, quite comprehensive document.
Exactly. Give you a shortcut to being really well informed on something that causes a lot of worry.
Okay, let's unpack this then. First things first, what actually is fever according to this guideline? What's the number?
It's very clear. Fever is defined as a body temperature of 38 degrees Celsius or higher, 38.0.
And crucially, how you measure that temperature matters a lot, doesn't it? It's not just like feeling the forehead.
Absolutely not. The guideline says rectal measurement is preferred. It's the gold standard for core body temp.
And that's especially important for the really little ones.
Yes, vital for children under 3 months. Getting an accurate reading is just critical for assessing their risk properly.
What about ear thermometers? They seem so much easier.
They are definitely more convenient. The source acknowledges that. But they're less accurate than rectal.
So they can tell you if fever's likely there, but maybe not the exact number.
Pretty much. And they specifically say don't use one if the child has an ear infection, could give a false reading.
Right, and the forehead feel.
Unreliable. The guideline just dismisses it for determining fever.
Okay, so fever is a number, 38 or higher. But the guideline also talks about what fever actually represents.
It does. It's usually a normal physiological response. It's the body reacting to an infection, most often viral, especially in primary care settings.
It's the body fighting back.
Exactly. That's its job.
And here's a key point, I think, maybe counterintuitive for some. Fighting the fever itself isn't the main goal.
Precisely. The guideline really hammers this home. Focus on the child's overall condition. How do they look? How are they behaving? Are they interacting? That's much more important than the number on the thermometer.
So medication isn't just about getting the temperature down.
No, it's about managing discomfort or pain. That's the primary reason to give it.
Okay. How long does the guideline say a typical uncomplicated fever might last?
Usually around 5 days, but, and this is important, it can persist for up to 10 days.
10 days. Wow.
Yeah, the data they cite shows 50% of kids still have fever on day 4, 25% on day 7, and even 10% are still febrile on day 10.
So a fever lasting, say, 4 or 5 days isn't automatically a sign of something sinister.
That's a critical takeaway, and it leads directly into another really important point the guideline makes.
Hope it is.
The duration of the fever, like having it for more than 3 days, is explicitly stated as not being a reliable predictor of serious illness.
Really? That feels like a big one. So
Yeah.
focusing on, oh, it's been 3 days can be misleading.
It can be, yes. According to this source, it's much more about the child's current state and the specific symptoms they're showing, not just how long the fever has lasted.
Okay, so if duration isn't the key factor for urgency, what is? The guideline puts a lot of weight on triage, right? That initial contact.
It does. Triage, often done over the phone, isn't about diagnosing. It's purely about assessing urgency. How quickly does this child need to be seen by a doctor?
And this is where it gets really practical, laying out different urgency levels. Let's talk about the highest risk category.
Right, the very short-term category, U1 or U2. This is for immediate attention, within hours. It includes all children under 1 month old with a fever, full stop.
Under 1 month, automatically highest urgency.
Yes. And also, any child of any age showing signs of being severely ill, deteriorating rapidly, or having unstable vital signs, using the ABCDE assessment approach.
And crucially,
The presence of just one specific alarm signal listed in the guideline is enough to put them in this highest urgency category.
just one signal. That really highlights how important those signals are. What's the next level down in urgency?
That's within a few hours, U3. This covers children aged 1 to 3 months who have a fever but don't have any of those specific alarm signals.
Okay.
It also includes older children who have known underlying health conditions that put them at higher risk, like serious heart or lung issues, diabetes, or if they're on immunosuppressants.
And then there's a category for needing to be seen within 24 hours.
Yes, that's for children over 3 months old if, for instance, the parents call back still concerned within 24 hours, or if the severity wasn't really clear during the initial phone call.
Other reasons for that time frame.
Yeah, if communication is tricky, maybe language barriers, things like that, Or if a fever went away and then came back after a fever-free period.
So if a child doesn't fit into those urgent categories.
But then, according to the guideline, self-care advice is appropriate. That comes with clear instructions on when parents should seek help again, of course. And this applies regardless of how long the fever has been going on.
Right. Let's circle back to those alarm signals. You said just one triggers top urgency. This feels like the most vital list. What are they?
Okay, this is really the core of when to worry. The guideline details them. First, age under 1 month, as we said.
Got it.
Appearing seriously ill, deteriorating quickly, or if the parents just feel the child seems different than usual, that parental gut feeling is valued.
Okay, parental instinct matters.
Lethargy is a big one. Very drowsy, hard to wake up, poor interaction.
Makes sense.
Inconsolable crying, or a cry that's weak or strangely high-pitched. Moaning or groaning sounds, too.
Right. What about intake and output?
Drinking less than half their normal amount, or especially in kids under 2, no wet diaper for half a day, a key sign of dehydration.
Vomiting.
Persistent vomiting, like multiple times an hour, even with an empty stomach.
Okay. Skin signs.
This is critical. Non-blanching red spots, petechiae or purpura. Spots that don't disappear when you press on them with a glass. That's a major red flag.
What else about appearance?
Pale, mottled skin, or gray or bluish color, especially around the lips. Cyanosis,
Breathing issues?
shortness of breath, really fast breathing, noisy breathing, particularly if there's drooling or pauses in breathing, apnoea.
And finally,
Any signs suggesting a seizure, like twitching or convulsions.
that's a thorough list. Really focuses on the child's overall state, doesn't it? Way beyond just the temperature or the number of days.
Exactly. These specific signs are the true indicators of potential serious trouble, according to these guidelines.
Okay, so let's say a child does need to be seen based on triage. How does the guideline say the doctor should assess them further?
Well, it involves taking a really thorough history from the parents, the anamnesis, and then doing a careful physical examination.
What kind of history details are key, according to the source?
They'll ask about fever duration, sure, but again, they really stress the parent's general impression. How sick does the child seem? Alertness, drinking, crying differently, fundamentally different from their usual self.
Hydration comes up again?
Definitely. Wet diapers, fluid intake, and any changes or worsening since the illness started. They also systematically ask about symptoms linked to different body systems to try and locate the source.
Like what?
Looking for skin rashes, asking about neurological signs like consciousness changes, vomiting, headache, ENT symptoms, ear pain, sore throat, respiratory cough, difficult breathing, gut issues, vomiting, diarrhea, urinary symptoms, pain, frequency, and even musculoskeletal joint pain or swelling.
And other background info.
Yeah, things like existing health conditions, vaccination status, medications, any sick contacts, recent travel, thinking about things like malaria, potentially.
Got it. Then comes the physical exam. What's the main goal there?
2 things. Assess the actual degree of illness, how sick the child appears, and try to find a focus, a source for the fever. Simple observation is key here, just watching the child.
What specific signs do they look for beyond the temperature itself?
Irritability, level of consciousness, how they react to parents, and the exam. Checking temperature again, rectally if under 3 months. Skin color, looking carefully for rashes. Assessing hydration, skin turgor, sunken eyes, dry mouth, sunken fontanelle in babies. And they mention a specific test, capillary refill time, CRT.
Right. How's that done again?
You press gently on a fingertip, or maybe the chest bone, for about 5 seconds, importantly, in a warm room around 20-25 Celsius. Then you see how fast the normal pink color returns.
And what does it tell you?
If it takes 3 seconds or longer, that suggests poor circulation, maybe an early sign of shock. But the guideline is careful. A normal CRT doesn't completely rule out serious problems.
What about checking for really serious things like meningitis during the exam?
They look for signs of meningeal irritation, neck stiffness, maybe a bulging fontanelle in infants. There are specific tests doctors can do, like Brzezinski or Koenig signs.
But these aren't always present.
That's a really important point the guideline makes, especially in very young children, under 1 year. These classic signs are often absent even if they do have meningitis. They might just be irritable or feeding poorly. So absence doesn't rule it out in that group. Assessing breathing and circulation is also vital, counting the respiratory rate, R, and heart rate, HR.
And fever affects those.
Yes, both tend to go up with fever. The source says breathing rate increases by about 2.2 breaths per minute for each degree Celsius rise. Doctors compare these rates to age-specific normal ranges.
What can abnormal rates mean?
Well, very fast breathing, tachypnea, could point to lung issues or even shock. Very slow breathing might suggest exhaustion or maybe brain involvement. High heart rate can be fever, but also shock. And then they'll examine other areas too.
Yeah, a systematic check of the abdomen, joints, limbs, ears, nose, throat, looking for that source of infection. So after all of the detailed history, the thorough exam, are tests usually the next step?
Well, this is interesting. The guideline is quite specific. Tests might be considered, but only based on those history and exam findings. They are not routine for most kids with fever in primary care.
Okay. What about urine testing? When is that recommended?
That's recommended if the doctor doesn't find a clear source for the fever after the history and exam, especially if the child seems moderately or severely ill.
Because UTIs can be sneaky in little ones.
Exactly. Symptoms can be very general in babies just seeming unwell. Older kids might complain of pain or frequency. The guidelines suggest a clean catch sample is best.
Now, blood tests, things like CRP. Parents often ask about those. What's the guidelines take?
This is another key insight. The guideline explicitly states there's insufficient evidence for the value of blood tests like CRP in the primary care setting.
Really? So they're not recommended routinely?
Generally not recommended for kids with fever in primary care. Given that serious bacterial infections are relatively uncommon in that setting, the clinical assessment history and exam is considered much more valuable than relying on a blood test number.
That's good to know. What about chest x-rays?
Also not routinely recommended just because a focus wasn't found. Pneumonia is usually suspected based on clinical signs like the child looking ill, coughing badly, breathing fast, showing retractions, or having abnormal lung sounds on listening, not just because they have a fever.
So it really sounds like the cornerstone is that detailed clinical assessment by the doctor, drawing on what the parents report and what they find on exam. Much more than jumping to tests in most cases.
That's absolutely the emphasis. Integrate all the information.
Okay, so based on that assessment, the guideline then groups children into risk categories to help decide what to do next.
Exactly. It helps structure the management plan, the below it, based on everything found.
Let's recap the very high-risk group. Who needs immediate referral?
Okay. Requires going straight to a pediatrician, usually hospital. It's all kids under 1 month with fever, all kids with any of those alarm signals we listed, all kids with unstable vital signs, and importantly, all kids aged 1 to 3 months with fever where no clear source was found on assessment.
So even if a 2-month-old seems okay apart from the fever, if the doc can't find an obvious cold or ear infection, they're very high risk.
According to this guideline, yes. The index of suspicion for something more serious, like a hidden bacterial infection, is higher in that specific group.
Got it. What about the increased risk category? Not urgent referral, but needs more attention.
Right. This includes those 1 to 3 month olds where a focus is found, like an ear infection, but maybe there's still some uncertainty if it's truly uncomplicated.
Okay.
It also includes older kids with underlying health problems, immunocompromised kids, or those showing certain symptoms from the risk assessment tools and the guideline things that aren't quite alarm signals, but still raise concern, like parent-reported paleness, definite change in activity, faster heart or breathing rate for their age, poor fluid intake, maybe some joint swelling.
And then the low-risk group. This must be the majority seen in GP practices.
That's right, typically the largest group. These are kids over 3 months where the source of the fever is clear, like a straightforward cold or ear infection. They have none of the signs or factors from the increased or very high-risk categories.
So they look pretty well overall, despite the fever.
Yeah, the guideline lists reassuring signs. Normal skin color, normal activity and alertness for their age, normal breathing and circulation, good hydration. These kids usually have a favorable self-limiting illness.
It seems very structured. But you mentioned earlier that clinical gut feeling still plays a part.
Yes, the guideline acknowledges this. The absence of alarm symptoms makes serious infection much less likely, but it doesn't completely rule it out. So that clinical intuition, the Dutch plus ne plus vol, that feeling of this seems okay versus something feels off, it still matters in the overall assessment.
To help with that assessment, the standard briefly covers signs of specific serious illnesses. Can you give us a quick overview from the source?
Sure. For meningitis, yes, the classic signs, neck stiffness, light sensitivity, bad headache are important. But the guideline stresses, again, these are often absent in young kids, especially under 1.
What might you see instead in babies?
Maybe just non-specific things. Unusual irritability, drowsiness, poor feeding. Makes it tricky, needs high vigilance. Then meningococcal disease, the really scary one. The petechiae, those non-blanching spots we mentioned, are highlighted as a very strong indicator. Needs immediate action.
Are there earlier signs for that?
Yes. The guideline notes potential early signs doctors look for, like cold hands and feet or severe leg pain, sometimes even before the rash appears.
And you mentioned Kawasaki disease earlier.
Yes, it's specifically mentioned as something to consider, especially with persistent high fever, like over 5 days, when there's no clear infection source found.
Remind us what that is.
It's a rare inflammation of blood vessels, mostly in young children. Diagnosis needs specific criteria. The prolonged fever, plus things like red eyes, conjunctivitis, a rash, changes in the mouth like red cracked lips or a strawberry tongue, swollen neck glands, and maybe red or swollen hands and feet.
And why is catching that important?
Because timely treatment is crucial to prevent potential heart complications like coronary artery aneurysms.
Okay, so the management plan flows from these risk categories. High risk gets referred.
Direct referral, yes. Low risk generally gets watchful waiting, with clear instructions for parents on what to watch for and when to come back.
And increased risk.
They need careful reassessment, maybe closer follow-up appointments, depending on the specific situation.
Now, medication. We said it's mainly for comfort, not just chasing the number down.
That's the message. Pain or significant discomfort is the reason. Paracetamol is the first choice safe, widely used. The guideline has dosing tables based on weightage.
And sometimes slightly higher doses for pain than just for fever.
Yes, the tables reflect that possibility if pain is the main issue.
What about ibuprofen?
That's the second choice, usually for kids over 1 year old. Again, dosing tables are provided, but there's a caution note. Be careful using it if the child might be dehydrated or has asthma or known kidney problems.
And here's another crucial point you mentioned earlier about medication.
Right. How well the child's fever responds to paracetamol or ibuprofen does not reliably tell you how serious the illness is.
So a good response doesn't mean it's definitely nothing serious.
Correct. And a poor response doesn't automatically mean it is serious. You just can't use that response as a reliable indicator of severity.
That's really practical advice. The guideline also sums up the main reasons for referral again.
Yes, just reinforces it. Age under 1 month, any alarm symptoms, suspicion of a specific serious illness like meningitis, sepsis, or Kawasaki, or if there's a need for diagnosis or treatment that just can't be managed in primary care.
Okay, let's talk about something that really worries parents. Seizures with fever. What does the guideline say about those?
Fever, seizures, or Quartz convulses are actually pretty common, affect about 2 to 5% of children, usually between 6 months and 6 years old.
And they often happen early on.
Yes, often right at the start of fever. Sometimes it's the first sign the child is getting sick.
The standard makes a distinction between typical and atypical seizures. Why is that important?
It's crucial for management. Typical fever seizures are generalized. The whole body shakes. They last less than 15 minutes. The child recovers fully within an hour. They happen in that 6-month to 6-year age range with fever in a child with no prior neurological issues.
And the key reassurance point.
They do not cause brain damage. That's important for parents to hear.
Okay, so what makes a seizure atypical?
Several things. If it's focal, just affecting one part of the body, if it lasts longer than 15 minutes, if the child doesn't fully recover within an hour, if it happens outside the usual age range, under 6 months or 6 years and older, or if the child has a known underlying neurological condition.
And atypical seizures raise more concern.
Yes, they suggest a higher chance of something more serious going on, maybe meningitis or another neurological issue, not just a simple fever seizure.
What's the advice for managing a seizure during the event?
Practical first aid. Keep the airway clear, turn the child on their side, protect them from injury, don't put anything in their mouth.
And after it stops, what's the assessment?
The doctor needs to assess the child, look for the fever source, paying close attention to any signs suggesting meningitis, though remembering those signs can be subtle in young kids.
And who needs referral after a seizure?
Children who had an atypical seizure, or if the assessment reveals any signs pointing to a serious underlying cause.
What about after a typical one?
For typical seizures, the guideline stresses reassuring the parents about the generally benign nature and providing guidance on managing potential recurrences. Sometimes this involves having rescue medication, like diazepam rectal tubes, available at home, with clear instructions on when and how to use it if another seizure happens.
It really sounds like managing parental anxiety and providing clear information is a massive part of putting these guidelines into practice effectively.
Huge. The guideline itself acknowledges common parent fears, brain damage, seizures, even death. These fears often drive the decision to seek help.
So clear communication is key.
Essential. Explaining things clearly, setting realistic expectations, explaining what signs are worrying and which aren't, aligning with the parents.
Does it mention cultural differences?
It does, briefly. Acknowledging that different backgrounds might view or manage fever differently, perhaps with more anxiety or different home remedies, and being sensitive to that.
And empowering parents with clear self-care advice is part of that communication too.
Absolutely. It's a crucial safety net. For kids managed at home, parents need clear instructions on exactly when to seek help again. If any alarm signs develop, if the child gets worse, if things aren't going as expected, or just if the parents remain really worried, that empowers them and ensures follow-up.
Okay, so let's try and pull all this together. After this deep dive into the Dutch guidelines, what are the absolute most vital takeaways?
All right, the key nuggets. First, fever in kids is incredibly common, usually harmless, mostly viral.
Right.
Second, focus on the child's overall condition behavior, alertness, hydration, much more than the number on the thermometer.
Okay, the whole picture.
Third, knowing and spotting those specific alarm signs is critical for knowing when to get help urgently.
The red flags.
Fourth, kids under 3 months with fever are always considered high risk and need seeing promptly.
Under 3 months equals high risk.
Fifth, and this might be surprising, the duration of the fever isn't a reliable sign of how serious things are.
Don't fixate on the number of days.
Sixth, antibiotics are rarely the answer in primary care, as most fevers are viral.
Right.
Seventh, medication like paracetamol or ibuprofen is for discomfort or pain, not just lowering the temperature. And how well it works doesn't tell you how sick the child is.
Meds for comfort. Response isn't diagnostic.
Eighth, typical fever seizures are common and generally harmless, but atypical ones need checking out.
Know the difference.
And finally, clear communication, addressing parent concerns, and giving specific follow-up advice are absolutely essential parts of safe and effective care.
That's a fantastic summary.
Yeah.
It really shifts the focus towards practical observation and specific warning signs, rather than just the fever itself.
Yeah, it moves beyond just the temperature reading to a more holistic assessment, guided by these specific evidence-based criteria.
So building on all of that, the structured guidelines, the specific alarm signals, but also acknowledging that clinical gut feeling, that plus goal, and the importance of parental concern. It raises a really interesting question, doesn't it?
What's that?
Given that clinical intuition and parent worry are right there alongside the objective signs in the guideline, how do healthcare professionals best balance that art of medicine with the science of these structured guidelines when they're faced with a child with a fever? And how can clear, consistent information best bridge that potential gap between the professional assessment and a parent's very natural anxiety to make sure everyone feels safe and reassured?
That's the real challenge in day-to-day practice, isn't it? The guideline gives you the framework, the map, but navigating each individual case, that takes skill, communication, empathy.
Absolutely. Definitely something for all of us to think about as we take this information on board.